Well, we'll welcome everyone, but we're going to wait just a few minutes. It's a little bit before 10 and people are still logging into the webinar. So just hang in there for a couple minutes. Good morning, everyone. We're just waiting probably another couple of minutes if that's okay with everybody, since we have people clicking in at a pretty good rate right now. And I see several people in the attendees list that I know, and good to see you all this morning. Just to let you know, this is a webinar, so attendees will be off camera and muted throughout. You'll be able to see the presentation as we move forward. Well, I have 10:01, so I think I'm going to go ahead and kick this off. Good morning, everyone. Thanks for being here. I'm Gary Harbison. I'm the Executive Director of the Missouri Coalition for Oral Health, and I want to welcome you all and just tell you very briefly that we're trying to assist providers with Medicaid, and so that has led to some kind of specialized webinars, and this is one of them. And so we appreciate you joining. We think you'll find this informative and helpful. And with that, I'm going to turn it over to Jessica Emmerich.
Thank you. Good morning. Thank you, everyone. Thank you for joining today's webinar, Realities of Medicaid, a Model of Anesthesia Services through HealthNet. We will be starting that presentation soon. The Missouri Coalition for Oral Health is a 501c3 advocacy organization. We're focused on policy and systems change to increase access to oral health services for all Missourians. You can learn more about Missouri Coalition for Oral Health and other upcoming events by visiting our website, Facebook page, Twitter, and LinkedIn. As Gary said, I am Jessica Emmerich. I'm the Dental Medicaid Facilitator with the Missouri Coalition for Oral Health. With the help of the Missouri Dental Association and HealthNet, we've been working with dental providers to increase Medicaid participation. As Gary said, through that work, providers have brought to our attention several barriers that prevent them from providing the necessary care for Medicaid patients. The Missouri Coalition for Oral Health's mission and vision is oral health for all Missourians. Today, we have Dr. Michael Todd with Accent Dental and Dr. Thomas Sake with Premier Anesthesia here to share their experience with providing anesthesia services and how Medicaid works in their practice. During the webinar, attendees are muted, but you can submit questions in the question and answer box. And with that, I think we have everyone has joined and we will start the presentation. I'll turn it over to Dr. Todd and Dr. Sink.
Morning.
Good morning.
One.
All right, so we're going to talk about a model for anesthesia services today through Missouri Medicaid. Again, I'm Dr. Sake with Premier Dental Anesthesiology, and with us is Dr. Todd, and we'll just get down to business here. Dr. Todd, do you have anything that you want to talk about on this particular slide? You want to jump in first each time?
I'll jump in a little bit. One of the things we get at our practices quite a bit with phone calls is someone will call up and say that they have Medicaid. And the first thing, and that they see us as a provider. So they'll ask us how to get an appointment. And the first thing we'll ask them is what type of Medicaid. And that starts a dialogue because there's two types of Medicaid, and quite a few of the calls we receive are from straight Medicaid recipients. And our practice is focused mostly on managed Medicaid.
Yeah, and I think this is a big point to make because a lot of people, providers and patients, don't understand that all Medicaid is not equal. In terms of providing anesthesiology care, straight Medicaid is really a non-starter for us. The fees do not support any sort of an engagement in office-based settings or in other settings, ASCs or hospitals. Kind of related to that, same with Medicare. Medicare really doesn't allow us to engage in these sorts of activities either. They're just not reimbursed at high enough levels to make it worthwhile. In Missouri, there are 3 managed Medicaid products, and those are currently UHC, Involve, which is a Centene product, and Healthy Blue, which is a product of Blue Cross Blue Shield. And these 3 companies do change from time to time. Every couple of years, we'll see someone exit and a new player enter. So that always causes a few struggles, which we'll talk about more in the next slide.
Okay, so this slide we've got about the dentist. So in order to participate in the program, you have to be credentialed, and you have to be credential. Well, each plan requires credentialing, so you don't do one credentialing and then all of a sudden you're credentialed for all 3 plans. You have to go to each plan. You don't have to participate with each plan. You can do 1 or 2 or all 3. The credentialing process is very time consuming. Mileage may vary. You may get credentialed rather quickly and talk to someone else, and they are still in the process of credentialing. It's been months. It's hard to say. There's a lot of moving parts to credentialing. I will say it's very demanding on whoever's doing the credentialing. In our practices, it's our office managers do that. They're very well versed at it, and they still spend an inordinate amount of time getting credentialed. So it's one of the first barriers you'll come across is when you go to sign up, you have to be credentialed.
Yeah, and we see a very similar thing on the anesthesiology side. First, we have to come to an agreement with a contract for each one of these individual carriers. And that can be very difficult. You can reach out to UHC or Involve or Healthy Blue, and you'll get a long litany of who should be talked to or should be contacted. And it's very difficult to find the correct person that can actually get you a contract that allows you to move to a credentialing stage. We've been able to do that over the years. We've been doing this for 15 years, but it is still very demanding. And we still struggle from time to time to get in touch with the right person at these organizations. Huge problem for us. And then once you are contracted to provide services with these 3 people, or these 3 carriers, I should say, then you have to get each individual anesthesiologist credentialed with them. And some of the carriers are relatively easy to deal with, and some of them are very difficult. And it can make actually bringing in new anesthesiologists difficult for our practice, because one carrier can get you up and running in a couple weeks, and the others might take a couple months. Meanwhile, you have an anesthesiologist that you have to figure out where you can place, because if you're not credentialed, you won't get paid. And so that's a huge problem in adding new staff and to getting staff credentialed when you start your program. And these providers, as I mentioned earlier, they change routinely. Every couple of years, we'll see one of these folks drop out and the new provider come in. And that starts the whole process all over again.
One other thing to add on my end is you have to be credentialed at each location. I have multiple practices, and for each practice, I have to be credentialed for that particular location. Once you complete the credentialing process, it's not that difficult to add an additional location that you're wanting to practice at, but you do have to add it. Okay, contracting. So with each plan, you have to sign a contract. The contracts are somewhat negotiable. Again, the mileage may vary. You can look over the language and see what you're comfortable or not comfortable with. Oftentimes there's language in there that talks about when you'll be available for services for their patients. It may discuss, like, for example, how often you're going to see patients. My feeling with that is they don't necessarily want people signing up that just want to see patients one day a month or something like that. That's my own personal take on it. Oftentimes there's a fee schedule in there as well. But overall, they expect Medicaid patients to be treated like any other patient. So I don't think, are looking to necessarily pigeonhole them to a certain time of the week to see them. They would like to see them be able to have access to care any day of the week, just like any other patient. One thing we do see more and more of is patients often have a blend of Medicaid and private care insurance. You don't always just see a patient that has strictly Medicaid. So that gets a little tricky. Our office managers have to be very well aware of this when the patient presents their insurance as to which plan they have and which private insurance they have, because the private pay insurance usually pays first, and then Medicaid will come in and pay second. And sometimes patients can get caught in the middle of that. So your office managers have to be very well versed in how to handle payer portions when you've got two different insurances, Medicaid and private pay. You're not allowed to charge for anything that's not covered. For example, if you do a case and as you're doing that case, something in that case is not covered by Medicaid, you can't necessarily go back to the patient and then charge them for that particular service. You have to make them aware beforehand that there's a possible procedure that you anticipate that may not be covered, and they have to sign a piece of paper that they understand it. There might be additional charges with that. This is critical with anesthesiology, because as you're doing an anesthesia case, things change on the fly. And so oftentimes we go into a case, we don't have x-rays necessarily, so we're taking new x-rays. And so communication becomes key for a lot of those folks, especially if they have blended insurance, because the last thing we want to do is go out and tell a patient there's going to be an additional, $500 charge for something. So it's very important to make sure your communication with your office manager, your assistants, and the patient understand how the insurance is working with Medicaid.
And then as far as anesthesia contracting, I think I spoke of this already. You got to have individual contracts with each of the three providers, and that can be difficult to accomplish at times. And then, of course, you need both of those things to fall into place to actually move forward with an office-based anesthesia dental program.
See, malpractice insurance. So with malpractice, in our cases, we have to notify our carriers that we intend to do anesthesia in our offices. In my particular case, it's an additional charge. They send you a form, my carrier does, and they want to know what type of cases you're doing, who's doing the cases, what type of other additional insurance you have for your facility, which that might dovetail into your business insurance somewhat. So there's a whole umbrella of insurance work that's involved with this when you start to do anesthesia in your practice. As a side note, several times we have to make sure that they understand that we're not actually the ones that are performing the anesthesia services, that we're working with board-certified anesthesiologists. Sometimes the carriers come back and they'll deny because they think we're actually doing it. So we have to make very certain that your carriers understand exactly what you're doing.
Yeah, and from that standpoint, we don't have to get involved in this portion other than just kind of assist the dental practices in filling out the paperwork. A lot of times the insurance companies have additional questions that they want to know what kind of equipment we have and what our backups are, and if we have malpractice insurance, which of course we do. But there's a lot of more technical things that they need to know for all the paperwork. So we try and help our dental practices fill this sort of paperwork out so they can get properly insured.
Okay, this is a big one: patient barriers to providing dental care. I'll just start on the upper one. So patient engagement, contact issues with pre-op. With with our offices, a lot of getting ready for an anesthesia case involves talking to the parents about what to expect with the anesthesia, and in particular, they can't have anything to eat 6 hours beforehand. So we have a lot of paperwork that they have to look at that discusses all the different things that they have to go through in order to get ready for the case. We also want to make sure that they're aware that if they miss the appointment, it can be very difficult for us to reschedule them. So we want them to contact us usually 24 hours in advance and let us know that they're going to be coming. We used to actually contact the patient. We still try to do that, but we also ask them to contact us. So there's a lot of communication that has to take place before we're ready to do anesthesia. No-shows are a big problem. That's one of our biggest problems, actually. So on any particular day, we're trying to do 6 cases, and oftentimes the evening before, we will not get a confirmation from someone, or we'll talk to them and they've got a sick child. So our office managers routinely will stay after hours, and we have a list that we keep of patients that are ready to go to start filling those slots. And it's even gone to a point where the day before we've had 6 cases lined up, and almost the night before we've switched all 6 cases out because of people that are getting sick, or they have transportation issues, things like that. Transportation is a big issue. Patients obviously have to get there. Some of them are relying on state transportation, and right now there's a big driver shortage. So we are seeing quite a few people calling up last minute saying that they don't have a way to get to us. So again, it can create no-shows on our list, which we don't want to have for Premier Anesthesia. So we work very hard to get those appointments filled. But you have to really be an advocate for getting your patients to that appointment. On patient demands, oftentimes that's one of the big ones, because some of our patients or parents can be very disruptive. That's a whole rabbit hole you can go down with that, but you have to be aware of your waiting room and what's going on out there. It kind of dovetails into the next one, patient encounters. Patients come in oftentimes or bring a child in for anesthesia, and sometimes they're intoxicated, or we can't do the case, or they're chemically impaired in some way. And again, we can't do the case. We have to be very diligent that the parent is able to take the child home. So it's something we have to watch for as parents come in. Translators, that's another huge one. We have a picture from our Brentwood practice. At one point, we had 7 different translators, 7 different languages in our waiting room. It was pretty cool. So you have to be aware that there's going to be language barriers oftentimes with that, and you have to anticipate that it's maybe your cost to provide for the translator. So that's something you can work with on your managed care carrier, but depending on the situation, that may be your cost. Also, if it's not your cost and you're trying to provide translators, you have to be able to either have a live person translate, or oftentimes set up some type of service where you can talk to your patient through your phone. There's various services available. We've had to work through all that at all 3 practices. One issue we run into is our practices. We have specialty care, we have an oral surgeon, we have specialists, we also have a lot of GPs, and your patients may go all the way up to age 20 years old. So if you're anticipating you're going to need anesthesia for just children, that actually is not the case. We have kids that are up to age 16, even 17, 18 sometimes, that need anesthesia services. And so as a provider, you have to be ready to go into an anesthesia case, extracting permanent teeth, doing some things that you may not be comfortable with. So it's good to know that those types of procedures could come up during anesthesia, because your patients aren't just going to be, say, ages 0 to 6 or 0 to 10. They're going to go all the way up to age 20. Just as an aside, our practices, even some of them take pregnant patients because they're eligible. Eligibility, that's a big one. You have to verify that your patients are actually eligible for service. And this is a big one for Premier Anesthesia, and Dr. Sake will talk about it in a second. If your patient is not eligible the day they walk in, they cannot be done. as far as getting paid for it. If you do the case and they're not eligible, you will eat the cost of that. And sometimes we do because we don't care about the cost. We just want the kids to get the care. So that's not a problem. Sometimes we don't want to turn someone away just because there's a glitch with their service. So we will just go ahead and do the case often because it's the most important thing is the kids get the care. But it's very important you verify eligibility. This becomes tricky because sometimes a patient will say, I know I'm eligible. It says right here that I am. We call the state. Turns out the state's claiming they're not eligible. It's just a glitch in the system. And this happens almost every week, it feels like. So it's a big issue. Again, the best thing I can say is when you're varying eligibility, you have to make sure they're eligible. Otherwise, you won't get paid.
Yeah, so we have all these exact same issues, but they impact us a little bit differently. Starting with the patient engagement, canceled appointments and no-shows. We go to great lengths to try and contact these patients preoperatively. I'll talk a little bit more about that later in the discussion. But simple things like getting a correct phone number can cause your staff to waste an hour of time. We'll call all the numbers, they'll be disconnected. We'll call the dentist that we're working with, and sometimes they'll have, there's another number. So it can really be difficult to contact these folks, both preoperatively and postoperatively. We have found in today's world, we actually do better texting folks. They're more likely to answer a text than they are to answer a phone call from a number they may not recognize. So at our practice, we've gone to a lot of texting when we try and get a hold of patients or parents because they're more responsive in this day and age. The canceled appointments and the no-shows, huge problem. The most likely cancellation of an appointment is going to be they messed up the do not eat anything after midnight rule. We can't put those patients to sleep safely in that setting. And so if they've eaten something, so those appointments have to be rescheduled. And then no-shows. It's amazing to me that you can talk to these folks the day before, they'll confirm their appointment, and then the day of, they just don't show up. In general, we probably do one less patient a day on average than what you schedule in your office due to this sort of thing. Our no-shows and canceled appointments and things like that are approximately 10% of all our appointments, and range based on dental provider from about a low of 3 or 4% all the way up to a high of 20-25%, depending on the practice. And so your dental practice, as well as us, has to be very cognizant of this and really stay on top of these folks to get them there. That's a huge step. It takes a lot of resources from both the dental and the anesthesiology practice. The patient demands, most of these folks are nice folks. They're very appreciative, but it only takes a few disruptive patients or one disruptive patient to really blow up your day or sometimes even your week. And you really need to have some office policy regarding appointments and what sort of behavior is appropriate. A lot of medical hospitals, offices are moving to a patient conduct agreement. A lot of this started out on the East Coast. Boston and Harvard program now has a patient code of conduct. Our organization is in the middle of adopting that, so that if patients are disruptive, we can dismiss them from our practice. We hope not to have to do that, but there's only so much your providers should have to handle, and I think your organizations have to stand behind your providers. In terms of patient encounters, chemically encumbered parents can be a problem. We really can't do a case if someone comes in like that, and it becomes even a greater problem if they disappear during the case. And when they return, they're chemically encumbered. Then we have to make a decision about who do we call to get this child home. So that can be a real problem in the middle of your day. And the translators, not only will they cost you some money, but they decrease your flexibility during your day. So you'll schedule a patient at 10, the translator scheduled at 10, and your first case cancels or doesn't show up, and you need to move that next case up. Then suddenly, not only do you have to get your patient there early, now you have to get a translator there early. And so it really decreases the flexibility that you can have in making your day efficient. And that can be problematic at times. Patients up to 20 years of age, as anesthesiologists, we carry all of the necessary equipment for a wide range of ages, but you do have to have that sort of equipment available if those are your patient populations. Patient eligibility. We have one person designated in our office that each day goes through all of the eligibilities as soon as they get to the office to make sure that no one's dropped coverage overnight. And you might think, well, gosh, if they had it the day before, certainly they'll have it the next day. Not always the case. And surprisingly more often than you would think. So you really have to stay on top of their coverage on the day of service. If I provide service on that day and they don't have coverage, that's free. That's a freebie, and that hurts me in the long run.
I think I'll add to that too, is there's a thing now we're seeing more and more. It's called retroactive termination. And this is where patients seem like they were eligible on the day of service. And then there's an audit done, usually by the plan, and it was determined by the plan that the patient, for whatever reason, was not eligible at day of service, and they will take all the fees back from that case for that day. And then you have to fill out or show your point as to why you felt like they were actually eligible that day. But it's another hassle you may have to go through.
All right.
Dr. Sake, this is probably all yours.
Yeah, you're probably not going to have a whole lot to add on these couple slides. Barriers to anesthesiology services. I really tried to break this down into 4 main categories, and I'll throw up a slide for each one of these. First and foremost, nationwide anesthesia staffing shortage. Not only the United States, but Canada, Europe, everyone's short on staff. And we're being asked to do more and more. So not only are we short on staff, but more people want us to be involved in the care. Efficient dentist, we have to go places that are efficient and that can go through a number of cases each day to make it worthwhile to haul all of our equipment to and from an office. The facility has to be appropriate for care. And I'll go through some of those problems that can occur and what I think is kind of some ideal situations for a facility. Patients appropriate for office-based setting. I'll go through this as well. Our nurses spend a lot of time on the phone trying to make sure that when the patient shows up, that they are indeed appropriate for office-based settings. So Jessica, if you go to the next slide. So the anesthesia staffing shortage, this was really becoming an issue as we entered 2019. And then everyone knows the pandemic hit the end of 19 through 20. First of all, we had the aging baby boomers, where you've got more patients. And of course, those baby boomers are choosing not to work anymore. That includes anesthesia providers. And so you have the aging of the baby boomers not only providing more patients, but less providers, because as those folks are retiring. In addition to that, you have hospital operating room growth. All the hospitals really are stacked in their operating rooms. Some are adding or remodeling rooms, and they keep asking us for more staff. And then within the hospital, outside the operating rooms, you have all these non-operating room anesthesia sites of service. And each year, I think we add another one of these. Originally, it was, can you do an MRI on a child? And then it became, we could use your help in CAT scan. Can you assist us in invasive radiology? to put a tube in an abscess. And then we have our dental colleagues that come to the hospital as well. Sometimes we do those outside the operating rooms. We have nuclear medicine that needs our services. We have oncology, and a big one is gastroenterology with upper endoscopies and colonoscopies. And this whole area of hospital NORA has really exploded over the last certainly 10 years, but even more so in the last 5 years, as the equipment and things have made it easier to be mobile in the hospital. All these areas are competing for anesthesia staff. In addition to the hospital areas, then we also have the surgery centers. All of those places would like to have more anesthesia coverage if they can. And then office-based procedures, which includes what we do at Premier Dental Anesthesiology, doing dental cases in offices. But there's other offices as well. We've had associations in the past with orthopedic surgeon doing hand surgery, ENT surgery, doing some cosmetic stuff on faces or noses. So as you can see, our dental colleagues are not only competing with other dental colleagues, they're competing with a multitude of other places that are pulling on our needs at a time when our staffing is getting shorter and shorter every year. All right. What I replied earlier about the pandemic, I just kind of wanted to show how this has really impacted us. This was brought in the ASA Monitor from November of 2022. Mr. Miller is a bit of a statistician, if you will, at the ASA. And they looked at the number of people who were dropping out of Medicare program. And from 2017 to 2019, there was a little over 2,000 people a year that would drop out. And that was kind of normal. After the pandemic, it's almost become twice as many. The number of drops in 2020 and 2021 far eclipsed and are greater than the previous years. And this all in the setting of people wanting more anesthesia coverage, not less anesthesia coverage. And this applies to not only anesthesiologists, but nurse anesthetists as well, and anesthetists, anesthesiologist assistants. Okay, but there is a little good news out there. If we look at the number of people interested in going into anesthesiology, the numbers continue to increase. On the left-hand side here, you've got the number of positions that are available in the United States. In 2023, it's around 2,000 positions. And then on the right side in green, you've got the number of applicants. In 2023, there was about 5,400 applicants for those 2,000 positions. So you can see that it's a very sought after residency position. I'm proud to say that my daughter just entered the anesthesiology residency at Washington University in St. Louis. So in a few years, maybe we'll have another one coming out. But it was a very sought after position. And a lot of people didn't actually match in those positions. We were thankful that she did. So you can see, however, if you look over to the left at the 2,000 matches each year, that's really not enough to effectively replace what we're losing at the rate we're losing doctors. And that's the bottom line, is how can we meet all this demand with a supply that's shrinking? And a lot of folks are starting to talk about increasing the number of residency positions in anesthesiology moving forward.
Okay, so this one, efficient dentists. So this has to do with the amount of time you get when you're doing an anesthesia case. And it comes up often. Typically, every case needs to be completed in one anesthesia visit. We don't have cases that we break up into 2 anesthesia visits. So the case may be something as simple as maybe a special needs child who just needs a cleaning and some x-rays and you're all set. or it could be a full mouth rehab. And I've done some that were up to 20 pulps and crowns. And you get about an hour to an hour and a half roughly because of the way the day works out. So you have to work very efficiently from my end to my assistant's end to making sure we have everything there that's ready to go. There's just not a lot of time. We always kind of say it's interesting how 5 minutes on one case doesn't seem like a whole lot, but when you're doing 6 cases a day, taking an extra 5 minutes is an extra half hour at the end of the day, an extra 10 minutes a case, and you've extended your day by a whole hour. So efficiency is extremely important. So you've got to work very well with your assistant. You've got to know what you're doing when you're going in there. As Dr. Sake will talk about in a little bit, we book usually 6 cases a day with the idea that one will drop off, but oftentimes all 6 show up. And because of what I mentioned earlier, where you have a lot of no-shows, we don't always know. When I go into the day, I don't always know what I'm doing that day, because they may have had to swap in 3 cases from the previous evening to keep the case schedule up for that day. So I may go in with 6 really big cases in a row. We go through a lot of coffee. So we've got to make sure you're working very efficiently on each of those cases. You don't always get to pick and choose whether you're going to do a small case and a large case. I walk in with the anticipation it's going to be quite a few full cases that day. So we do a variety of procedures. A lot of our patients, a lot of these kids have really, unfortunately, a lot of decay. And so you go in, and a lot of them what looks like on the surface to be a small case rapidly turns into something that's becoming a very large case quickly. Oftentimes we can't get x-rays on the patients while they're awake, so we don't get our x-rays till they're asleep, and then we realize every tooth has an interproximal cavity, and what you thought was going to take you 10 minutes is now up to an hour. And again, you're just having to work very proficiently. Scheduling and commitment to patient arrivals. Again, we deal with no-shows, and so last minute sometimes we're swapping in cases very quickly. Illnesses, kids get sick oftentimes, so again, we deal with that on the no-show basis, and we go back to that list again, and oftentimes, again, the cases are pretty big that we'll pull off that list. I talked a little bit earlier about the confirmation. That's a big one. We try to confirm patients as much as we can. Sometimes we'll call a patient like an hour before the case. They'll say, yep, we're on our way. We'll have some patients that say, yes, I'm parking, and then we don't ever see them. So we're not sure what happens. But again, it's a big thing with getting the patients to the practice and actually in the chair. And that's why we keep that backup list of patients. Completion of cases, we really try hard not to run behind. It can be very stressful when you've got a large case and you're trying to get your crowns to fit right, and you know your next case is there, and sometimes your next 2 cases are there waiting for you. So you've got to, again, work very efficiently. You're not allowed the luxury of letting a case back up for 2 hours, because what will eventually happen that we've seen is your 4th and 5th case will leave oftentimes. And so that's a loss for Premier Anesthesia, because they obviously need the cases. It's a loss for the practice. So if we have a case that's running behind, we try to be very cognizant of making sure the next patients know. Otherwise, again, they tend to leave. So x-rays, again, are a big one. Like I said, the kids, they don't always cooperate for x-rays. So most of the cases we see, we go in without having any x-rays in advance. So we'll have to take new x-rays. One of the things we run into with the anesthesia cases is sometimes we'll have x-rays, but because a patient's no-show for an anesthesia visit, or they've left town, or for whatever reason, and there's a delay between we actually see them for their initial exam and when we see them to do the work. And so even though we have x-rays, we may have to retake all of the x-rays as well. And that adds time to the case. Again, you have to have a very proficient assistant, because the assistants can't be spending 20, 30 minutes of your roughly hour to hour and a half you have for the case just taking x-rays. And again, the last one, like I mentioned earlier, if you start falling behind, 10 minutes even on a case starts to stack up throughout the day. By the end of the day, you could be running an hour or 2 behind, which puts a lot of demand on first you, your parents, and then especially your staff, because a lot of times people aren't going to want to stay an extra hour or 2 while you get your anesthesia cases completed.
Yeah, along these lines, I mean, we really have to align ourselves with dentists who can be efficient in their offices, and it's more than just the dentist doing the work. As Dr. Todd mentioned, it's the dental assistant taking the X-rays. It's the commitment of their office staff to make sure these folks are getting here, getting their transportation, getting there on time, just getting there, period. And then you've got, you know, this you need to complete a certain number of cases to make it worthwhile. So from an anesthesia standpoint, we've tried to tailor our anesthetics so that our turnover time is much shorter than it would be, for example, if you were in a hospital. Of course, being in a dental office with close proximity to pre-op and post-op, those things all help in those efficiencies, but so can your actual drugs that you use to provide an anesthesia. And as Dr. Todd mentioned, if I spend an extra 10 minutes in between each case and we're doing 6 cases, we just blew almost an hour. So if I can pare that down, it really helps in getting these things done on a timely basis.
One thing we've seen also is if you're doing anesthesia cases, oftentimes other patients in your waiting room, they don't understand what's going on. They'll come in and they don't realize the patient that's going back for anesthesia is there for anesthesia. And so sometimes they'll bring food and drink into the waiting room, and that's not good for a child who's been there 6 hours or has gone 6 hours with nothing to eat or drink. And that's one of our confrontational points, believe it or not. People, want to bring food in that waiting room. And so we'll have to explain it. If you're doing anesthesia that day, we don't allow it. We don't allow it anyway, but especially if we've got kids that are ready to go to sleep. And then they also don't understand that the patients are going back for anesthesia, which is different from their own child who might be going back for a cleaning or, so we get the question, why did that patient go back before me? I've been waiting here 20 minutes. So it takes communication again with the other patients of what's going on your anesthesia days. And then not so much with us anymore because we've designed our practices to allow for this, but the anesthesia cases wake up. And oftentimes they're when they come out of the anesthesia, they can be noisy, they're loud, or they're hollering whatever. Sometimes they come out very cleanly and they're not making any noise, but oftentimes the patients in the waiting room can hear that and wonder what's going on back there. So it can be a little disruptive if some of the post anesthesia cases are being noisy and it filters out to the waiting room.
Which is appropriate dovetail for the appropriate facilities.
Yes.
You set me up great there. Thanks.
So
yes.
I could talk about this one. Do you want me to
go ahead.
Start with this one? So we just went through this because we just expanded our Brentwood office, and it's completely designed to handle anesthesia. I worked very closely with Dr. Sake and his team to get all their input on what they needed in the practice to do this. And because you're not only working with logistics of how to get your patients into the anesthesia area and out of the anesthesia area, you're working with the logistics of the codes. You have to have, as we see on the slide, various physical attributes to your practice to handle the anesthesia and meet code. There's exhaust fans that you have to have for the gases. You have to have a certain amount of space for Premier to be able to work within. So your operatories have to be large enough to be able to get the equipment in and out. Once Premier's in there, because usually the anesthesiologist is sitting with your patient, you've got to have enough room for your assistants to be able to get in and out. In your recovery rooms, you have to have suction and oxygen supplied. And depending on your facility, and we've been through this somewhat, the dictates for that might come down from the National Fire Prevention Code. They look at the anesthesia gases and how they're being exhausted and making sure it's not a potential fire hazard. And Dr. Say can talk about that a little bit. The post-op area, again, it's a big one because when the kids wake up, a lot of them, they're hollering and the noise can filter out to the other parts of the practice. You've got an awake child who's going to receive a procedure, and next thing you know, they hear something of a kid hollering. They don't understand why, and so they can become very afraid. Parents in particular can become afraid. They don't understand why a child is hollering over there. So again, communication becomes very important. You have to really train your staff to let them let parents know what's going to be happening that day while being aware of HIPAA. Also, your recovery area has to be big enough to be able to get a wheelchair in and out of, ideally, or in our case, we use a wheelchair. We also have a stretcher because we do see bigger kids that we need to place on a stretcher. So you got to have the facilities you can get that in and out of. How you exit the patient becomes a big deal because a lot of times the kids, they're still pretty out of it when they leave. Sometimes they're safe, but as they leave, we might have some gauze packed because we've taken some permanent teeth out or whatnot. And to exit them through the waiting room can make some big eyes as they see that patient leaving. They don't understand what went on. So like at our new facility we just put in, we have a separate exit door that we can exit them out of the building without having to take them back out of the waiting room. So all considerations with your setup.
Yeah, and this is something that I go through with all the dental practices that we work with, or especially if you're thinking about redesigning a space or building a new space. You know, these are kind of our suggestions to you. The 6x8 is really feet. That's how big the space should probably be at a minimum. Exhaust fans are nice in preoperative areas. Some of these folks come in and quite frankly, they reek of marijuana. And so you don't want your next patient who may not be of that type to have to smell that. So an exhaust fan is very nice. Of course, something to keep them occupied, a TV while they're waiting for us and while they're waiting for our pre-medications to set up, chairs to sit on. And a door is important, as Dr. Todd mentioned. Any place you can put a door is probably a good idea because it muffles sounds and everybody just does much better. The operative area, the big thing there is our supplies and equipment take up a fair amount of space. You really need about a 12 by 13 foot area for your room, which is bigger than most people design dental suites. You got to have the area clear around the head and the sides of the patient for us to manage the airway and to get our equipment easily in, and then also to work around. Depending on how your operatory area is set up, your dental assistant, if they want to go get something during the case, may have to walk around all our equipment. So there needs to be enough space for them to be able to do that. Again, a door is a great thing in an operative area. We need suction for patient care as well as for anesthesia waste gases. In 2018, the National Fire Prevention Association published new guidelines, formerly known as NFPA 99 guidelines. And specifically, Chapter 15 dealt with anesthesia delivery in offices. So there were enough anesthesia services being delivered in offices that the Fire Prevention Association decided to throw down a bunch of regulations, not only on waste gases, but also on gas pipelines if you're using a central pipeline for your gas service for providing anesthesia. And one of the biggest things is the suction. They may determine that you need a separate suction for the anesthesia waste gases compared to the normal suction that you use throughout the rest of your practice. And the reason for that was the fire triad, if you will. If you have oxygen as an oxidizer, which we use a lot of in anesthesia, if you have a spark or an igniter, which could come from an oil-based suction pump, and you have something there to burn, you need all those three things to make a fire. And the National Fire Prevention Association thought that by bringing in higher levels of oxygen, it placed some of the oil-based pumps at risk. But after making all these regulations, there's a little clause in there that says, we'll let the local fire marshal decide what they want to have you do or not do. So our experience with this has been, we have had one fire marshal who said, yes, you have to put in a separate pump system for the anesthesia waste gases. And the rest of them have not cared to make us do that sort of thing. So that's something that I always tell people, you'd have to work with your local fire marshal, invite them into your practice and see what they think. In most instances, though, if you're not remodeling and having the open your walls, or you're not building an entire new site of service, they're not going to make you put in a secondary pump, has been our experience. The post-operative area, again, an exhaust fan for the same reasons as the preoperative area. Dimmable light is nice. And then we either use a recliner or a stretcher or a dental chair, works well as well to recover in. But the area does have to have some oxygen and suction. And again, a door is great to keep the noise down. A fair amount of these children wake up with emergence delirium. That lasts typically for about 14 minutes on average, and can be very uncomfortable for everyone. So we work really hard to communicate that to the parents preoperatively, and to everyone involved in it, so that when it happens, it's not a surprise, because it is relatively common. And then last but certainly not, you have to invite the Missouri Dental Board into your office to get a Missouri Dental Board site certificate. They will do an inspection of your office to gain that certificate as well.
There is some additional wear and tear on your facility with doing anesthesia. For example, in our Columbia office, we're getting ready to replace our flooring because, for example, in the pre-op rooms, oftentimes the kids are given a pre-med, which is usually some Tylenol with some type of medication in it to help them relax. And oftentimes they don't swallow it, they just spit it right back out. So that's going on your floor. So if you have a carpeted floor, that doesn't always work well. You'll be cleaning it a lot, or you can switch to a hardwood floor. And same thing in recovery. Again, there's body fluids, and you've got to be aware of your facility that everything needs to be cleanable. Ideally, you've got to be able to wipe everything down. So if you're looking at a post-op area that's carpeted, or is the walls aren't going to be cleanable, it's something to consider. If you're going to be doing anesthesia cases, you're going to have to work to make those areas disinfectable. Pre-op history, Dr. Say can talk extensively about this. So not every patient can be done. Oftentimes the patients have existing medical conditions that can allow them to have general anesthesia, but oftentimes can't. And although Premier can screen these patients out, we have all of our staff trained as well, because we want to prevent that at the exam appointment or the recall appointment. And I say recall because a lot of times their medical histories change. So the last thing we want is to say, yes, this kid can have anesthesia, and then we tell the parent this, and they go over everything, and then we turn them over to Premier, only to find out that they have some sort of medical condition that would prevent them from getting anesthesia, and it's a disservice to everyone. So training your staff is critical. Everyone from office managers down to our assistants, everybody understands Premier's criteria, so that they can talk to patients about if there's an issue that they see that might prevent their child from getting anesthesia. Sometimes we need to, knowing these conditions, we'll even write in advance of even getting Premier involved, we'll write consultation letters with their pediatricians, whoever else we might need to sleep issues are a big one. A lot of times the kids have had sleep issues. It's becoming more and more of an issue. So we'll try and get those boxes checked for Premier before Premier ever comes on site, so they're not having to deal with that. In worst case, get a case canceled because we didn't do our due diligence.
Yeah, and we really appreciate kind of that screen before the screen, if you will. It just saves everybody a lot of time and hassle when our dental colleagues appropriately screen before they send them over to us. It's a huge benefit when that's done properly. In our service, we have nurses. We have a couple nurses every day in the office, and they sit there and call patients and get preoperative histories to make sure that they're appropriate for an office-based anesthetic. In general, we only do ASA 1 and 2 patients. Those are essentially healthy patients. In the pediatric world, and an ASA 2 that we take care of your office would be somebody who has well-controlled asthma, for example. We don't do kids or anyone with a BMI greater than 30. There are too many problems with trying to take care of morbidly obese patients to be done safely in an office. Premier doesn't do kids less than 10 kilos. Thank goodness they usually haven't rotted their teeth out before then, but it does happen from time to time. And we'll make them wait until they are big enough because it's just too many problems otherwise. And we certainly wouldn't do anyone who had a history of difficulty being intubated or somehow having their airway managed. So you really have to focus on this patient selection and preoperative history to provide safe care in an office And we err, quite honestly, on the side of conservatism. If we're worried about doing a case, we probably shouldn't be doing it in a dental office. And those patients are probably better served in a surgery center or a hospital setting. So didn't really want to make this into a commercial about Premier, and wanted to let other people know that there are other providers in the state of Missouri. Premier started in 2007. We've done over 65,000 cases in the last 15 plus years. We use board certified anesthesiologists exclusively with anesthetists and nurses. We have our main office is in St. Louis, but we have satellite offices in Kansas City, Columbia, and Springfield. So we're spread all over the place. And out of the St. Louis office, we also service the markets of Rolla and Cape Girardeau. There's another company called Mobile Anesthesia Care, or MAC. They started doing this in 2012. They're out of Kansas City. They do some work in Springfield and Joplin, I believe. So they travel a little bit. I think they actually do a little work in St. Louis as well. And they're board certified anesthesiologists that work closely with nurses as well. And then there's also solar practitioners in the state. Some folks who give anesthesia while doing their own cases, other folks who give anesthesia more along the lines that we do and allow the dentist to do the work. So there are choices out there for your anesthesia provider.
We've worked with Premier from since 2008, almost from the inception, I think, with Premier. We did our very first cases in Columbia with them and have just grown over the past 15 years with them.
Yeah, and so I just want to kind of run you through how we do some things. This isn't necessarily how each company does their thing, but this is how we do things. We typically have the RNs do a pre-procedural phone interview and you give them instructions. That's as important as the interview itself. And then those nurses get that health history and they ask some directed questions. Specifically about things that may impact our anesthetic, like does your child get frequent nosebleeds, or have they ever had to have their nose cauterized if we're thinking about doing nasal endotracheal tubes, which we do. So that sort of pointed health history is very helpful for us to provide the care. And then the anesthesiologist reviews that health information with the nurse who did the review and creates an anesthetic plan. And then for our basic pediatric procedure, this is how we do things. Other people, I know the MAC group, they do primarily an IV anesthetic, so different than us. There's many ways to quote unquote skin a cat, but we typically use some Versed for sedation, either by mouth or nasally prior to the procedure. Eases the separation from the parents, makes it a lot easier for everybody. Children don't then remember having a smelly mask of anesthetic agents applied to them. We'll take them to the operating room. The parents may not come back with their child. We want to focus solely on the child. And then they're induced for general anesthetic by mask. They breathe phthalofluorane and nitrous oxide. Once they're asleep, we start an IV, we manage their airway, and then at the end, we remove the airway and the IV, and we take the kid to recovery. We have the parents come back shortly after we get them into recovery, and we watch them for about 20-30 minutes until they meet our discharge criteria, and then they can safely go home.
So dentist benefits, familiar surrounding, that's key. We do all of our anesthesia, of course, out of our practices. We've got 3 of them, one in Brentwood, one in Wentzville, and one in Columbia. Everybody's been trained. They've attended the Premier Anesthesia courses. That's everybody that's working with the anesthesia. I used to do cases over at University of Missouri, and great facility. I loved working there, but they're just not as efficient, of course, as having the in-office anesthesia. And of course, you can schedule more cases because of that per day. So it's allowed us to see many more kids under general anesthesia by seeing them in office. and this goes back to what I just said. We've got our 3 facilities. I think we've completed something with Premier of over 30,000 anesthesia cases, Dr. Sake, maybe more.
I think it's around that number. It's a fair amount of what we've done over the years. Absolutely.
Quite a few. Our practices in general, we do private pay insurance as well, but the majority of our practice is the managed care plans. Last year we had over 50,000 patient encounters, so we have quite a few patients that come through our practice. So we're very appreciative to have the anesthesia services there in-house. And we just recently expanded our Brentwood practice with an anesthesia-based type of facility. And again, it goes what I just said, the patient benefit, because the patients are already there. Usually we've seen them for an exam or a recall. They can come in and they familiar with the facility already when they're coming back for their anesthesia visit. We don't charge a facility fee to the patients, and then we don't get a facility fee from the plans. We just everything is done under the fee schedule. I can see the last slide there, Jessica, condensed visit. Yeah, just versus setting in a hospital. They don't have to wait if they're going to a hospital. Audits are a big thing. We've been audited several times. Now they don't audit. It was more when going back several years ago. Now they don't audit us. The audits usually seem to come back very clean. There's nothing they seem to say, which I guess we're doing something right, which is great. Initially with audits, sometimes they will use it to claw back fees. One of the things we would often see is if, say, for example, you did a buckle on number 30, and for some reason in your chart it said an occlusal on 30. They will pull back the fee you got paid for that case. Everything has to match up. What you performed off has to match up with everything in your notes. If it doesn't, they will take that fee back. So we're very diligent about how we do our notes. Everything that we would bill for code-wise winds up in the notes for that purpose. It does take extra time to do audits. The very first audits took hours and hours and hours. So, and I think they tend to, I could be wrong, but I think they tend to target newer practices that are signing up for audits to make sure they're just doing everything they're supposed to be doing. Obviously, no one wants fraud. We're very diligent of that. And so, but also just to make sure you're doing things correctly. And again, there's no rhyme or reason to it. Apparently it's done just whatever practice, but just be aware that if you're doing Medicaid, managed care, your practice could be subject to an audit, and they'll just ask for random charts. And if they find things that there's discrepancies, it may result in fees being taken back. And it's also going to take an inordinate amount of time for your office managers to deal with audits, because they've got to pull the charts, prep the charts, get them all sent over, write letters of explanation.
Yeah, I see the audits as, everybody's happy. The patient's taken care of, the dentist is doing well, we're doing great, everybody's feeling good. And then suddenly, bam, they hit you with this audit. It's a deflator. And they do try and aggressively claw back fees. It's extremely time consuming. It can be very irritating. And at times it seems very arbitrary. And at times it can come down to just some confusion. We had a company audit us a few years ago, and said that we didn't have all sorts of things in our anesthesia record that we were supposed to have, and I maintain that we did. And finally went to a conference call with them, and we found out that they had asked for our anesthesia record, which, if you ask for an anesthesia record from an anesthesia company, they will send you the time graft page out of the patient's chart. So all they had was that one page. They didn't have the full charts. And once I started explaining this to them, then they realized that their entire audit had just fallen on its face, because they thought that that was the only piece of paper we had for the work we had done, when indeed we had 10 pages of work. They just didn't correctly ask for what they wanted. So you really have to spend a lot of time, though, and a lot of meetings to get through these audits. And it's pretty painful. And I think that's probably the last slide that we have.
Yeah. One thing I want to add that just I was remembering, when you have a child that you think needs anesthesia services, you have to write a narrative. And this is for every plan, all three managed care plans. Before you can put that child on your anesthesia schedule, you have to write a narrative into the plan explaining why they need anesthesia. So basically, every case has to be pre-approved for the anesthesia. You can't just say, well, this child needs anesthesia, we'll go ahead and put them on the schedule. They have to get approved. So it's going to take some extra time to write that narrative. Usually the narrative involves explaining why you think they need to go to sleep, whether they're a special needs child or they're just not able to handle an exam.
Yeah, a lot of great information from you guys. Thank you. Okay, we are at 11 o'clock, so we have taken up the full hour. Would you guys like to go ahead and take some time to answer question and answers?
Sure, I'm happy.
Sure.
Okay, so the first question I'm seeing is the recent Medicaid unwinding. Has that affected your practice? Has it contributed to the broken appointments?
What was the question, Jessica?
The recent Medicaid unwinding. So we know that patients are losing eligibility because of the unwinding when they're being reevaluated through HealthNet. Have you noticed that that's significantly made any difference in broken appointments lately?
Yes, we have. We've been sending out my office manager, my regional manager. She's been great at being aware of this. And she has sent out notifications either through text or mailings or whatnot, letting people know that make sure that they're reapplying for their benefits if they're eligible. Yeah, we're very cognizant of it. We have seen a drop off.
I think that's something that's we're seeing a lot among all practices, not necessarily just anesthesia. So great question and great concern, something we're definitely still working on. Okay, there was another, just a comment looks like here. The Dental Anesthesia Center has been providing dental and care and general anesthesia services for 31 years. So it's great to know that there's other anesthesia centers out there and available. Definitely do your research, see what's available in your area. Again, we know that these patients are needing this care, and we're hoping that providing this information will help encourage Medicaid providers to start working with their anesthesiologists in their areas and get these children seen, get these patients seen. I'm not seeing any other questions coming through right now. You guys have provided a lot of wonderful information. We hope this has been very helpful to those who that have attended. Thank you guys for taking time out of your day to attend and share this information. Okay, sorry, I'm just trying to make sure there's no other questions here. Okay, there's one here that said, I've heard there's a rule that children under a certain age, possibly 5, have to be approved for general anesthesia sedation if they have significant needs. Do you know if that's correct? Are there extra?
In the state of Missouri, in the state of Missouri, insurance has to cover general anesthesia for children who have dental work by state law, if they're less than 5. Your commercial medical insurance, that is, specifically.
Okay, great. And again, if our attendees have other questions, feel free to reach out to Dr. Sake or Dr. Todd. You can reach out to myself at the coalition. I'll do my best to help answer any questions that you may have about these services, but this has been very helpful and we really appreciate you guys being here today. I think we're going to go ahead and be respectful of people's time and go ahead and work on closing out today's webinar. Again, if you guys have questions, feel free to follow up with us afterwards, but we appreciate you guys being here today, and thank you again for all this information.
All right. Thank you for having us.
Thank you.
All right, everyone have a great day.
You too.
Thanks.